You already know this feeling. The alarm goes off, or you wake on your own. You sit up, swing your legs over the side of the bed, stand. And then, those first few steps to the bathroom. The feet feel wooden, the ankles feel thick. There is a strange disconnect between what your brain is telling your legs to do and what they are actually doing. You move forward, slightly uncertain, slightly stiff, slightly unlike yourself. And then, somewhere between 10 and 30 steps, it passes. You straighten up, you feel normal, and you do not think about it again until tomorrow morning. You have done this for years. You have never mentioned it to a doctor because it goes away, because it does not seem like something, because somewhere along the way you made a quiet agreement with yourself that this is just what mornings feel like now. I need you to set that agreement aside for the next hour, because those first steps are not just what getting older feels like. They are a physiological report, 3 separate systems in your body reporting simultaneously every single morning about things that are happening inside you while you sleep. And those 3 reports, if you know how to read them, tell you something specific, not vague, not general, specific, about the state of your connective tissue, your joints, and your cardiovascular system. Most people have been reading that report as a single sentence. This is age. Today I am going to teach you to read it the way a clinician does. I am going to name all 3 systems, but I am not going to name the third one yet, because the third one is the one that nobody connects to this symptom. The one that changes the clinical picture entirely for a subset of people watching right now. If I tell you what it is before you understand the mechanism, you will hear the name and either dismiss it or panic. Neither of those serves you. So we go in order. Stay with me. What I am about to show you is the most complete clinical picture of this symptom that exists outside of a specialist's office. And by the end of this video, you will know exactly how to translate it into a conversation that changes how your doctor hears you. I want to tell you about Miriam. Miriam is 69 years old. She spent 35 years as a nurse, a career in which she watched patients, monitored symptoms, and understood better than most people how the body communicates when something is wrong. She came to see me not because of her morning stiffness. She had lived with that for years. She had attributed it to her arthritis, accepted it, and built her mornings around it. She came because her husband had started watching her, not commenting, not asking, watching. The kind of watching a person does when they have decided not to say something yet. She had noticed it from the corner of her eye, him standing in the doorway of the bedroom while she made those first few uncertain steps to the bathroom. Just watching, just waiting. And that silence had frightened her more than any symptom. When she sat across from me, the first thing she said was this: "I'm a nurse. I know what morning stiffness means. I've known for years. What I can't explain is why it's getting longer. 6 months ago, it resolved in 15 seconds. Now it takes a minute, sometimes more. That part I can't account for." That sentence, that shift from a stable symptom to a progressive one, is the most important clinical distinction in this entire video. I am going to say it again, because it is the thing I want you to carry with you today. Here's what matters. Morning stiffness that has been the same for years is a different clinical picture from morning stiffness that is getting progressively longer, more intense, or expanding to times of day when it did not previously occur. The symptom is not the signal. The direction of travel is the signal. If your first step stiffness has been exactly the same for 5 years, that is one conversation. If it has been worsening over the past 6 months, that is a completely different conversation. Both matter. But the second one is urgent. The medical system is particularly bad at this specific distinction. Morning stiffness is one of the most commonly dismissed symptoms in primary care because it resolves before anyone can observe it. By the time you are sitting in the appointment, it is gone. By the time you describe it, it sounds like something manageable. And the attribution, it's your arthritis, it's your age, drink more water, closes the conversation before the right questions are asked. This video exists to open the conversation back up with the right questions. There are 3 types of people watching this right now. The first type has morning stiffness, has had it for years, has attributed it entirely to arthritis, and has not noticed any significant change. Stay. Because what you learn today will change what just arthritis means to you, and it may prompt an investigation that has never happened. The second type has noticed the stiffness getting progressively worse, longer to resolve, more pronounced, happening now after sitting in a chair for 20 minutes, not just in the morning. This video is specifically for you. I am asking you not to leave early. The third type is watching because someone they love has first steps that have become noticeably slow, shuffling, or uncertain. You may not be able to make the appointment happen, but after this video, you will know exactly what to say to the person who can. The three systems behind those first steps have names. Two of them you have almost certainly heard of. The third, the one nobody connects to this symptom, is the one I find most important in clinical practice. Because when it is the primary driver, it changes the conversation from a physiotherapy referral to a cardiovascular investigation. I will get there, but I need to take you through the first two first. System 1, connective tissue. The first system is the one that explains most of what most people feel in those first steps, and it starts in the sole of your foot. Running from your heel to the base of your toes is a broad, dense band of fibrous tissue called the plantar fascia. It is not a muscle. It is not a tendon in the traditional sense. It is a ligament, a structural band, and it bears the entire compressive load of every step you take. In a young, well-hydrated, well-rested foot, it functions like a spring. It absorbs the impact of your foot hitting the ground and releases that energy to propel you forward. It does this thousands of times a day without you thinking about it. But here is what happens while you sleep. The plantar fascia, like all connective tissue, has a resting state. When you are lying flat and non-weight-bearing for 7 or 8 hours, the collagen fibers of that tissue settle into a slightly shortened, slightly stiffened alignment. The ground substance, the gel-like matrix that fills the space between those fibers, becomes more viscous, more resistant to movement. Scientists call this the thixotropic property of connective tissue. It becomes more fluid under mechanical stress and more viscous at rest, not diseased, not damaged. Physics. Think of it as a cold rubber band. It does not snap, but it does not stretch as freely as it will once it has been warmed and used for 30 seconds. The first few steps to the bathroom are your foot doing what the rubber band does in your hands before it warms up. This explains the most common pattern of first step foot stiffness. Worst in the very first step, improving rapidly within the first minute of movement, primarily felt in the heel and the arch. It is morning dominant because that is when the longest unloaded rest has occurred. It may also happen after sitting for extended periods during the day for the same reason. The tissue has had time to return to its resting state. This pattern is extremely common in adults over 60, and in most cases, it is manageable with targeted intervention. But I want to name something specifically because it concerns a significant number of people watching. 2 classes of medications are documented to worsen connective tissue stiffness in ways that go beyond normal age-related changes. The first is statins. The same mevalonate pathway inhibition that reduces CoQ10 production in muscle cells also affects tendon collagen synthesis. The collagen fibers that make up the plantar fascia, the Achilles tendon, and the ankle ligaments are less efficiently produced and repaired in patients on long-term statin therapy. The result is tissue that is less elastic, slower to warm up, and more prone to micro-injury under loading. The second is fluoroquinolone antibiotics, ciprofloxacin, levofloxacin, moxifloxacin. These carry an FDA black box warning for tendon damage. The damage is mitochondrial and can manifest weeks after the course ends, at a point where the connection to the antibiotic is no longer obvious. If your first step stiffness began or significantly worsened after a course of antibiotics in the past 3 to 6 months, that temporal connection is not coincidence. It is a clinical question. How do you know if this system is your primary driver? The connective tissue signature is this: stiffness most intense in the very first step or two, located primarily in the foot, heel, and lower ankle, improving rapidly within 30 to 60 steps as mechanical loading warms the tissue. It responds well to weight-bearing movement specifically, not just time. Sitting back down does not help. Walking does. The connective tissue system explains most of what most people feel. But for some of you watching, what I just described does not quite match. The stiffness does not resolve with movement, or it is in the whole leg, not just the foot. Or it comes with a heaviness that feels less like tightness and more like the blood has not arrived yet. If that description is closer to your experience, stay, because the third system, the cardiovascular one, is exactly what produces that feeling, and it requires a completely different investigation. System 2, the synovial joints. The second system sits above the foot, in the knee, the hip, the ankle joint capsule itself, and it involves a substance that most people have never thought about. But that, once you understand it, explains something about your mornings you will never stop noticing. Inside every major joint in your body is a sealed capsule filled with synovial fluid. This fluid is the joint's lubrication system, a thick, viscous substance produced by the inner lining of the joint capsule. When the joint is loaded and moving, synovial fluid distributes across the cartilage surfaces, reducing friction, absorbing shock, and nourishing the cartilage cells that have no direct blood supply of their own. When the joint is at rest for several hours, that fluid pools. It does not distribute evenly. The cartilage surfaces that have been in contact overnight are less well lubricated than they were at the end of an active day. When you take the first step, the full weight of your body loads that joint before the synovial fluid has redistributed. The cartilage is less protected for those first seconds. If the cartilage has any thinning, and after 60, most knees and hips have some degree of cartilage change, that brief under-lubricated moment is felt as a grinding, a stiffness, a reluctance in the joint itself. The joint needs to be woken up. Now here is the distinction I need to make because it is one of the most clinically important things in this video and it is almost never communicated to patients. There are two types of arthritis, and they feel different in the morning, and that difference tells you something specific about what is happening inside the joint. Osteoarthritis, mechanical arthritis, the wear and tear kind, produces stiffness that is worst on the first loading of the joint and improves with movement over the next 5 to 15 minutes. It may worsen again with prolonged use later in the day. It tends to be localized to one specific joint. It is a mechanical problem. The cartilage is thinned, the joint needs lubrication, and movement provides it. Inflammatory arthritis, rheumatoid arthritis, psoriatic arthritis, and related conditions produces stiffness that is prolonged, not 5 minutes, not 15 minutes. Inflammatory arthritis morning stiffness lasts longer than 45 minutes, consistently. It may last hours. It is accompanied by a sense of systemic fatigue that is different from tiredness. The affected joints may be warm to the touch. It does not resolve with movement in the way that osteoarthritis does. 45 minutes. That is the clinical threshold. That is taught in every medical school, and it is almost never communicated to patients. Many people with rheumatoid arthritis carry an untreated or undertreated condition for years because nobody told them that the length of their morning stiffness was a specific named clinical signal. I want you to do something tomorrow morning. Set a timer from the moment you take your first step to the moment your stiffness has substantially resolved. Not approximately, actually time it. And do that for 3 consecutive mornings. Write down the number. Under 30 seconds. Primarily connective tissue, likely manageable. 30 seconds to 45 minutes. Joint and connective tissue, warrants monitoring. Consistently over 45 minutes. This is a clinical flag. This is a number to bring to your doctor, not a description, a number. If inflammatory arthritis is the underlying cause, the blood tests that reveal it are specific. High sensitivity C-reactive protein, HSCRP, and erythrocyte sedimentation rate, ESR, are the inflammatory markers. Anticyclic citrullinated peptide antibody, anti-CCP, is the more specific test for rheumatoid arthritis. Many people with RA have had elevated inflammatory markers for years before anyone ran these tests. Request them by name. I will give you the exact language later in this video. 2 systems. Connective tissue, synovial joints. Together, they account for the majority of morning first step symptoms in adults over 60. But I told you there were 3 systems, and the third one is the one I said nobody connects to this symptom. I am going to take you there now, and when you hear it, I think you are going to understand something about your own mornings that you have never had language for. System 3. The cardiovascular system. Let me describe something for you. Right now, somewhere, a person is getting up from their chair. Their legs feel heavy, not stiff, heavy, like the blood has not arrived yet, like something has not switched on. They wait a few seconds, it improves, they move on. They have done this hundreds of times. Nobody has told them that what they just experienced was their cardiovascular system reporting something specific, not their joints, not their ligaments, their arteries. Here is what is actually happening. When you stand up from sitting or lying down, approximately 5 to 700 milliliters of blood, almost a liter and a half, shifts from your chest and upper body into your lower extremities under the force of gravity. This is just physics. The blood goes down, your cardiovascular system has to compensate for that shift within 30 to 60 seconds. Your heart rate increases. The blood vessels in your periphery constrict to push blood back upward. The veins in your legs contract to accelerate venous return. When this compensation works perfectly, you feel nothing. You stand up and you are simply standing. But here is what happens in adults over 65 when this system is under stress. The compensation is slower. The blood pressure drops in that 15 to 30 second window before it recovers. And during that window, the tissue of your lower legs, your calves, your feet, your ankles, is momentarily underperfused. The blood has shifted downward, but the delivery system has not yet caught up. And the first steps taken in that window do not feel like stiffness. They feel like heaviness, like uncertainty, like the legs are operating on a slight delay. That is orthostatic underperfusion. And it is one of the most common cardiovascular experiences in seniors over 65. Now I want to add the second layer. For a subset of people watching, and I want to be specific about this subset, the legs feel heavy on first steps because the arteries supplying them are narrowed, not completely blocked, narrowed. This is peripheral arterial disease at its earlier stages, before the cramping and pain that most people associate with it. At rest, narrowed arteries can just barely maintain adequate blood flow to the lower extremities. When you stand up and the metabolic demand of your leg muscles suddenly increases, and the gravitational redistribution simultaneously reduces the driving pressure, the narrowed vessels cannot keep up. The first steps are taken in a state of brief ischemia, reduced oxygen delivery to the working muscle. It lasts seconds. It improves as collateral circulation recruits and the muscles adapt. But it is not nothing. And it is not age. It is a vascular finding, and it can be measured. I said earlier that I find the third system the most important in clinical practice. Here is why. The person with connective tissue first step stiffness needs a physiotherapy referral and possibly a medication review. The person with inflammatory joint disease needs a rheumatology referral and specific blood tests. But the person whose first step symptoms are driven by the cardiovascular system needs something different. They need a conversation with their prescriber about whether their medications are making this worse. They need a vascular assessment, and in some cases they need a cardiovascular evaluation that nobody has initiated because nobody connected the morning heaviness in their legs to the arteries feeding them. Let me name the medications, because this is the part that most people watching have never heard. Antihypertensive medications, blood pressure drugs, alpha blockers in particular, but also certain ACE inhibitors, ARBs, and calcium channel blockers at higher doses can exaggerate the blood pressure drop that occurs on standing. Your medication may be controlling your seated blood pressure beautifully while simultaneously causing a 20 to 30 point systolic drop every time you stand up. That drop is the first step heaviness. That drop is the uncertain legs. And it is happening because the medication is doing exactly what it was designed to do, just at the wrong moment. Loop diuretics and thiazide diuretics reduce your circulating blood volume. Less volume means the orthostatic compensation has to work harder and faster to maintain pressure when you stand. In the morning, when you have been lying flat for 8 hours and your body is at its most volume depleted, the compensation demand is highest. The first step, heaviness, is worst. And nobody has told you that the water pill you take for your blood pressure or your heart failure is the reason your legs feel uncertain when you get out of bed. Beta blockers blunt the compensatory heart rate increase that normally corrects the blood pressure drop on standing. The heart cannot speed up as quickly to compensate, so the underperfusion window lasts longer. The first steps feel uncertain for a few seconds longer than they should, and certain antidepressants, tricyclics in particular, and some SNRIs, cause peripheral venous pooling through their alpha-adrenergic blocking effects. Blood pools in the leg veins, venous return is reduced. The first step perfusion deficit is worsened. The clinical reality. Here is the clinical picture I want you to understand. The person most likely to have cardiovascular first-step symptoms is the person whose medications are working. Their blood pressure is controlled, their cardiologist is satisfied, their most recent readings were perfect, and every morning when they stand up, their legs are briefly reporting something that no one in the clinic has asked about, because it resolves in 30 seconds, because nobody is there to see it, because the appointment happens when everything is fine. You are the only person who observes these symptoms in real time. After this video, you will know what they mean, and you will know what to do about them. The diagnostic distinction between the three systems is something I want to give you as a practical tool. If your first step symptom is primarily in the foot and heel, improves within 60 steps, and responds specifically to walking rather than just to time passing, connective tissue is the primary driver. If your first step symptom is a stiffness in a specific joint, the knee, the hip, the ankle, and it takes longer than a minute to resolve and is worst after the longest periods of rest, synovial joint disease, either mechanical or inflammatory, is the primary driver. Time it. If your first step symptom is a heaviness, an uncertainty, a feeling of the legs operating on a slight delay, that improves over 30 to 60 seconds of simply being upright, not foot movement specifically, not joint movement, just standing. That is the cardiovascular autonomic signature. Many people have elements of all three. Most people, if they are honest with themselves, can identify which one is strongest. That identification is the beginning of the right conversation. Now I want to give you the test, the specific 90-second home test that tells you whether the cardiovascular component of your morning symptoms is clinically significant. It requires nothing except a blood pressure monitor, the kind you can buy at any pharmacy for $30. And the result it gives you is not vague. It is a specific number that has a specific clinical threshold. If you are on blood pressure medication, this test may be the most important thing you do this week. I am going to give you 4 things before the doctor dialogue: a timing protocol for tomorrow morning, the 90-second home test, the blood tests to request by name, and the self-assessment that tells you which conversation to have. The morning timing protocol. Tomorrow morning, before anything else, set a timer the moment your feet hit the floor. Stop it when the stiffness or heaviness has substantially resolved, when you feel essentially normal. Write down that number. Do it for 3 consecutive mornings. Write the average. That number, in seconds or in minutes, is a clinical document. It is not a description. It is data. And data changes how a doctor hears you. The 90-second orthostatic test. You need a home blood pressure monitor, standard upper arm cuff. If you do not have one, they are available at any pharmacy for around $30 and are genuinely one of the most useful health tools a senior can own. Step 1. Lie flat on your back for 5 full minutes. Do not get up yet. Take your blood pressure while lying down and write down the systolic number, the top number. Step 2. Stand up immediately. Within 60 seconds of standing, take your blood pressure again. Write down the systolic number. Step 3. Subtract the standing number from the lying number. A drop of more than 20 points in systolic pressure or more than 10 points in diastolic pressure meets the clinical definition of orthostatic hypotension. A drop of more than 30 points is a significant finding that requires a conversation with your prescriber. Do this test twice. Once in the morning before you take your medications. once 30 to 60 minutes after taking your morning medications. The difference between those two readings tells you something specific about your medication's contribution to the orthostatic drop. If your drop is more than 20 points, write it down, date it, bring it to your next appointment. This is not a symptom you are describing. This is a measurement, and a measurement changes the entire character of the conversation. Blood tests to request by name for connective tissue pattern symptoms. Foot and heel dominant improves rapidly with movement on a statin or recent antibiotic course. Creatinine kinase or CK. This is the marker of muscle and tendon cell breakdown. An elevated CK in someone on a statin with tendon stiffness symptoms is a documented laboratory correlate of drug-related connective tissue damage. For joint pattern symptoms with morning stiffness lasting more than 45 minutes, high sensitivity C-reactive protein, HSCRP, erythrocyte sedimentation rate, ESR, anti-cyclic citrullinated peptide antibody, anti-CCP. These are the three tests that distinguish inflammatory arthritis from mechanical arthritis. All three can be ordered by a general practitioner. None of them is exotic. Many people with undiagnosed inflammatory arthritis have been managing it as osteoarthritis for years because these tests were never run. For cardiovascular pattern symptoms, leg heaviness, uncertainty, or a positive orthostatic test, ankle brachial index, the ABI. This test compares the blood pressure at your ankle to the blood pressure at your arm. In a healthy arterial system, these two pressures are approximately equal. When arteries are narrowed, the ankle pressure drops relative to the arm. An ABI below 0.9 indicates peripheral arterial disease. This test takes 4 minutes. It requires a Doppler probe. Not all general practices have one. If yours does not, ask for a referral to a vascular clinic or vascular medicine practice. Requested by name, ankle brachial index. For any pattern with a possible medication contribution, request a formal medication review specifically focused on orthostatic effects, not a general medication review. One focused on this question. Which of my current medications have known effects on blood pressure when changing position? That framing gets you a specific, relevant answer. Write these down, or stay on this section and replay it. These are the exact words. Your exact words at your next appointment. I also want to give you 3 questions that apply to all 3 systems that you can use regardless of which pattern most fits your experience. First question. Can we establish a baseline measurement today, either grip strength, timed stiffness, or orthostatic blood pressure, so that we are tracking this as a clinical parameter rather than a description? The moment you have a number, your symptom is no longer anecdotal, it is longitudinal data. It changes what the next appointment can do. Second question, is the trajectory of this symptom, the fact that it has been progressively worsening over the past X months, something we should investigate now, or are we waiting for a specific threshold? This question forces your doctor to name what they are watching for, and once it is named, you can both monitor for it. Third question, is there anything in my medication list that is likely contributing to this symptom? And what would a trial reduction or timing adjustment look like if we decided to explore that? You are not asking to stop anything. You are asking to understand the medication's contribution and whether it can be modified. That is a clinical conversation, not a confrontation. Let me bring this back to Miriam. Miriam's orthostatic test showed a 26-point systolic drop within 60 seconds of standing. She was on an ACE inhibitor and a low-dose thiazide diuretic. Her anti-CCP antibody came back positive. She had inflammatory arthritis that had been managed as osteoarthritis for 3 years. 2 separate clinical conversations had been needed. Neither had happened in any of her previous appointments. Her GP moved her antihypertensive to an evening dose. The morning orthostatic drop reduced from 26 points to 9. Her rheumatologist started a low-dose anti-inflammatory protocol. Within 6 weeks, the morning stiffness that had been lasting 90 seconds was resolving in under 20. 3 months after her first appointment with me, she called my office, not to report a transformation, not to thank me for a miracle. She called because she wanted to tell me something specific. She said, He stopped watching from the doorway. Her husband, the silent watching that had brought her in, it had stopped, because the first steps that had frightened him no longer gave him reason to watch. That, she told me, is the thing I couldn't have described to you when I first came in. I thought I was coming because of my legs. I was actually coming because of the doorway. Those first steps are not just age, they are a report from 3 systems that have been trying to communicate with you every single morning. Today you learned to read that report. The next step is making sure the right person in your clinical care reads it too. Before you go, I have one question for you. How long does your morning stiffness take to resolve? Not approximately, in seconds or in minutes. Time it tomorrow morning. Then come back and put the number in the comments. Just the number. Because I have a strong suspicion about the distribution of those numbers among the people watching this channel. And when you write yours, someone watching tonight who has been told for years that their number is just age is going to see it alongside yours and understand for the first time that they are not alone in asking this question. If this gave you something your appointments have not, subscribe. Free. First link below. When you write to me, I write back. Important. Read before acting. If your home orthostatic test shows a drop of more than 30 systolic points, or if your first step symptoms are accompanied by chest pain, significant shortness of breath, or a sensation of near fainting on standing, these warrant a same-day or urgent call to your doctor, not your next scheduled appointment. Do not wait.